Good afternoon, everyone. So I thought that I would start by talking about the impact of cachexia because to manage it appropriately, we have to understand its impact on the people who have cachexia. So cachexia affects people who have it in a multidimensional way, but commonly it affects them clinically and it has also impact on their psychosocial status. So clinically, it's been demonstrated in several studies that cachexia is associated with poor prognosis, poor treatment outcomes, poor functional status, poor quality of life, and increased hospitalization. Then in the psychosocial domain, the main impact arises from what food means to people, and as well as what bodily changes happen to people when they have cachexia. So when one has cachexia and loses a lot of weight, usually there is a change in the sense of self and challenges in identity, and they develop a negative body image. Sometimes people actually cannot recognize themselves, as expressed in this quote. This patient had cachexia, and when they looked at themselves in the mirror, this is what they saw. This bony thing shows up in the mirror every morning, and my eyes fall on this creature on the other side of the mirror. So they can't understand, is this really me, or is it a creature I'm seeing? And the changes in physical appearance are accompanied by the change in social encounters and relationship. When other people see them, the way they react to them. And of course, like this patient expressed, I was 5 feet from him before he could figure out who it was. I cried because he was a very, very good friend of mine. It seemed to confirm the fact that I was so skinny. So even other people cannot recognize them. So it really becomes very distressing. A sense of being different can prompt feelings of helplessness, loss of control, abandonment, and stigmatization. And this can precipitate anxiety and distress. Also because weight loss leads to function loss, there is loss of independence, because as one loses function, they become more and more dependent. And this can be a source of distress because no one wants to be a burden to others. So as you become more dependent on others, you feel more distressed. And also, weight loss provokes thoughts of imminent death. I think Peace will explain more about this when she comes to present. As I said before, food means a lot to people. It is more than nutrition. Preparing and serving food is associated with caring relationship. We use food in social activities, and meals are heavily loaded. We use them in celebrations, happy times, sad times when people die, and for memories. So when somebody loses ability to eat, or they cannot eat, this impacts a lot on their families. It disrupts their daily routines, changes their roles, and opportunities for interpersonal interaction. As this carer had to say about his patient, I cooked a lot. He ate what I made because I made what he liked. We always ate together. He wouldn't eat if I didn't eat. So I stopped eating when he stopped eating. And dinner hour, I didn't realize until he stopped eating that there was a dinner hour. And then there was none, and it was so difficult to get through the day, because what do you do from 5 to 7? That part of your day is empty. So when carers see that their patients are not able to eat, and yet they are losing weight, they become very anxious. So they start forcing them to eat, and telling them, you're really losing weight and you're not eating. And then this causes conflict between the patient and their carer. And then as they force them to eat, they actually eat less. And this becomes a vicious cycle of not eating and frustration and conflict. So this brings a sense of helplessness to the family and guilt for the family if one cannot eat. As this man said, that it was so frightening to see her lose weight. I knew something was drastically wrong. I blamed myself for not feeding her the right things. So they start thinking, maybe I'm not doing something right, and that's why this is happening. Also, for families, if they can contribute to your care by giving you food, that allays their anxiety. It's a defense against their anxiety, and they see it as a way they can fight illness. So I'll move on to assessment. In all patients with advanced illness, it's important to screen them for cachexia. That is a weight loss of more than 10%. unintentional. And careful history should be done so that to assess the nutritional issues, including risk factors which compromise ability to obtain or take in nutrition. So those are the secondary causes of cachexia they talked about. Are there other things that cause loss of appetite? And then nutritional intake should be assessed. And some people use prospective diaries. It may be difficult for us to use, or the 24-hour recall. Then on a physical exam, weight should be taken, and the height, and the BMI. But there's a lot of debate on use of BMI to measure cachexia, because it doesn't account for things like edema. So if somebody has edema, their weight will be higher than actually the real weight, and then the BMI will be falsely high. So that's the limitation of using the BMI. So people are actually debating whether they should only be using the BMI to determine cachexia. Then assess for loss of subcutaneous fat, as Moira said, that subcutaneous fat and muscle wasting, because these are lost in cachexia. And you look at those areas, presence of edema and ascites. The other things that are used to measure weight loss or muscle loss are more used in the research setting, like the mid-upper arm circumference, and they are not very accessible to us as clinicians on the wards. So pharmacological interventions. So, okay, I think I've lost the slide. So, right. Okay, so treatment of cachexia can be non-pharmacological. It should be multimodal, really, because as you've seen, there is problems with metabolism, but also there are psychosocial impacts which arise with cachexia. So treatment should address all these. And we have the non-pharmacological interventions, which will include giving them foods which they want to eat. You should take care of, you should ask them what they want to eat. Their appetite, what they want to eat, should take priority over their caloric intake. And then give small, frequent meals, which they are better than giving big meals. And then give foods which have less odor, because if you're nauseated and you take a food with a strong odor, then you become more nauseated. And then the pharmacological interventions, there are not so many, but so far from research, the ones that have been found to be very useful include megestroacetate, which is a progesterone analog. And in this Cochrane review, it was found that compared to placebo, it improved appetite and was associated with weight gain in cancer patients and in HIV patients, and those with other underlying pathology. But it had limitations in that it caused thromboembolism, hypogonadism, and adrenal insufficiency. However, these were not very common, and it said that they shouldn't limit its use, but it should be used at lower doses. The other pharmacological treatments are glucocorticoids, and again, these from several trials have been found to be efficacious, but their action is actually very short-lived. So they are recommended for people who are at the end of life, who want to eat, prefer to eat, and you're not really caring about whether they want to gain on weight or not. But these studies have been done in only malignancies, and there's no data on steroid use in non-malignant conditions. Other medications which are being tried have been tried, but the trials have been small, so the evidence is not sufficient, include cannabinoids and cytokine inhibitors, non-steroidal anti-inflammatory drugs, thalidomide, anabolic steroids, growth hormone, and ghrelin, and prokinetics. And it's thought that some of them have actually produced very good results, but were limited by bad side effects. And others, it's just difficult to tell because of the small sample sizes. Okay. So I talked about the non-pharmacological ones. And there are other drugs in research. This you can have a look at afterwards. They all are targeting the pathophysiology of anorexia cachexia. How about artificial nutrition? complete anorexia-cachexia syndrome, it's been found that despite increased nutrient delivery, trials have showed disappointing results in improving clinical outcome in cancer. So unless you are able to switch off that process that drives the anorexia-cachexia syndrome, the primary one, then you're unable to improve outcome of patients with just artificial nutrition. But in starvation, actually there's been a survival benefit if patients were put on gastrostomy feeding, especially in those who had early head and neck cancers and mechanical GI obstruction. So again, it emphasizes the point which Moira was saying, that when you have a patient who is before you who has a low BMI, you want to assess, is this primary cachexia or secondary cachexia? And then if it is primary, you know that artificial nutrition will not help. But if it's secondary and it's early on in the disease trajectory, they are not dying patients, it can benefit a lot if you offer it. Okay, yeah, so that's it.
Thank you very much. So we've talked about the impact. I'm going to talk